Don, I want to start off by thanking you for taking the time to be with us today. I know the students are going to learn a lot by hearing from you, and I know you're very busy, so I really appreciate it.
My pleasure. I wish we could share a glass of wine at the same time, but anyway, we'll proceed.
Well, if we can figure out how to do that, you and I will probably get very rich.
Well, we've got a lot of wine up here in Charlottesville, so I always try to help the locals.
Yes, you do. Um, so, Don, I mean, you've been a thought leader in informatics for years. You chaired most of the important IOM reports that I've alluded to throughout the course, so you have a unique perspective. Where do you think we are today on transforming our healthcare system, particularly through the use of health IT? And what are your hopes for the future?
Well, it's really been exciting to have been involved in this. I guess the only thing that's frustrating is that I'm not getting younger because I think it still has to play out, but we are really, I think, making terrific progress. When you consider that the 1991 report on the computer-based patient record was called an essential technology for healthcare, and that it took until just 2009 for the high-tech legislation to really make this a national kind of development with meaningful use and so forth. So clearly these have been really momentous times, and it's exciting to me to see that we are way past the early majority. We're into the late majority of people now doing this, both in hospitals and practices. So having said that, I don't know if you saw, I can send you the reference, but I had a paper with a couple colleagues this year. The wave is finally broken, where are we now, that spoke to some of the issues. And there are a lot of issues out there. There's not the interoperability that we need. There's not the functionality that we need from the point of view of even physicians, let alone all the other members of the health team. So it's a glass half full, half empty kind of thing, but actually I think it's really in a good spot. Some of where we are, though, is, of course, we mostly have been using health IT in terms of, say, computer technology, and I think increasingly now we're using communications technology, and all these things are new from the time the study was done and it moved forward. So we're always going to be in the situation of trying to both keep up with where the technology and opportunities go, but a lot of progress has been made, and I think what I'm excited about to talk about also is where some of the pinch points are and where we can go next.
Well, I will certainly post that paper for the students to read. As we look at a healthcare system that is increasingly using digital records instead of paper, the research community is very excited about the prospect of having access to huge amounts of digital data to study it, to help improve care, or gain new knowledge, and maybe even improve the healthcare system itself. But I don't have to tell you, getting to that data is often a very difficult, time-consuming process, mostly because of concerns about patient privacy. Some people feel maybe the pendulum has swung too far on that, and maybe we're actually harming our ability to use digital data as a result. What's your view?
Well, in fact, I am one of those people that believe that. Some of the issues are not necessarily the HIPAA legislation per se, but clearly I think HHS has not, in fact, creatively tried to manage to this, to balance these competitive goods. Privacy is a good thing, but too much privacy, and obviously you can't have knowledge, you can't run a government, you can't run research and so forth. And I think the problem with, the principal problem with HIPAA was that it was built in an era that was all pre-internet. So the fact that you could do data analytics and do translational bioinformatics and know the human genome and proteomics and epigenetics with epidemiologic data as well, let alone using it to improve healthcare systems with clinical alerts and even community health approaches using public health dimensions of this. All of that was well before HIPAA. So candidly, I've been spending hours up on the Hill with Energy and Commerce staff to try to see if we can, as part of their initiative, to improve, really cures is where they're wanting to go, but care as well. See how we can hopefully make some reforms in these things, because right now it's not only a problem for research, it's also a problem for education too. I hear issues where pharmacy students are interested in trying to learn how to do data mining and looking at drug use and so forth. Can't get to the record data in some schools for some various reasons. And as I say, the issue is not only the legislation, which was built for a different era, mostly clinical trials where the patient was at risk, to secure use of these data for data analytics, where honestly the risks are extremely small. I think actually if you look at the hospitals around the country that are doing research, most patients actually overwhelmingly want doctors to do and other health professionals to do this research, and in fact actually are sort of assume that we already were doing it. So we really clearly have some issues here, and there have been cultural issues where not all scientists have eagerly wanted to share data, but I think the Clinical Translational Science Awards have really cracked into that. Plus, what has happened in the last 100 years is the human species has not only been very productive, but they've been very reproductive too. And as a result of that, the human genome's gotten more complicated. So if we're going to really crack these things, which we can, we really need very big data sets. And you can't aggregate those, in fact, where you talk to a group of patients or patient advocates with one problem, because a lot of these are multi-dimensional kinds of problems. In fact, most of them are. They're not single gene or single issue, single dimensional issues. So anyway, tremendous opportunities, but also candidly, we're leaving a huge amount of discovery on the table. Another quick example, HIPAA says you can use personal health data, identifiable data for doing quality studies in a hospital. But if you find something that really you'd like to share with your neighbors and colleagues and publish it, you got to go all the way back to an IRB and start all over. Well, busy people may not want to mess with that. Now, in some big institutions, they spend a lot of money and extra effort to help facilitate people being able to deal with that. But we can't afford to lose that wherever it is, smaller institutions or larger institutions. So we got to work smarter. We can't work harder. I think the government's not going to throw more money at healthcare. That's I think becoming increasingly relevant for both research as well. So we've got to get better data liquidity, as the term is called, and let it move around for care, for research, and then also ultimately then for population health.
Well, you've mentioned patients a number of times, and I think most people would agree that patients are the ultimate decider when it comes to the use of their data. And a number of people have suggested that patients create their own data repositories that might be housed in a PHR or some other tool, specifically for the purpose of mediating the sharing of their data. Do you think this is an inevitable development? Do you think it's a good development if it happens? Might that be the way to increase the accessibility of clinical data for research and other purposes?
Well, if it were the only approach, I'd be strongly against it. Mostly because we know at least 25% of people really don't care if their data are used for anything, but they don't want to be bothered to be asked about it. So anytime you're carving out 25% of the population, and keep in mind the population may be split differently. For example, a number of years ago, Minnesota passed a law that said you had to get people's permission to use their data. And it turned out Rochester was doing a lot of work also in breast cancer, particularly in younger women. Well, in Minnesota, it was very disproportionately young women who decided to opt out of having their data shared. Well, as a result of that, nobody could do research because their sample sizes weren't big enough. And obviously, I think that's the challenge. It sounds kind of good from a patient autonomy point of view. But I don't think it's any way to get discovery in an era where big data, where you really can try to get to the core of things and create real cures. Now, if you're talking about certain areas, I'm not saying that it's uniformly a bad idea, but if we only had one arrow you could shoot, frankly, I think we need to decide that as a society, we care enough about each other that we're going to share our data to cure things so all of us can live longer and live better lives. And also, by the way, have a cheaper healthcare system, which we clearly need as well. So I don't know if that's responsive, but that's a quick answer.
No, that's a great answer. Well, Don, I think the students have really gotten some tremendous insights here from someone who's been obviously one of the great thinkers about this for many decades now, and I appreciate you sharing those insights with the students and taking the time with us. Thank you very much.
Well, you're very gracious. I enjoy when we can get together, and obviously hope that can happen more often in the future. If a particular student does have a question that they'd care to write to me about, I'm not saying how quickly I'd get back to them, but detmer@virginia.edu, and I'd try to respond. And I'll also send a few references to you that might be potentially useful.
All right. Well, thank you very much.
Yeah, thank you. Have a good day.